All right. Hello, everybody. Today we're going to be talking about pain control and sedation in the ICU patient. We've got Graziella here. She is our PharmD extraordinaire. She works primarily with us in the trauma ICU at ECMC, and she's going to step slightly out of that role today to talk about pain and sedation more in the medical patient, particularly in the COVID population, and how that fits in with the usual critical care patient. So, Graziella.
Great. Thank you, Dr. Cooper. So thank you everybody for tuning in, and hopefully you can come away from this short presentation with a little bit better understanding of kind of what things have changed since you may have practiced in the ICU yourself, and a bit of information of how to handle the sedation in these complex patients. So I just kind of want to summarize a bit of an overview of the general pain and sedation approach for the ICU patients. So in general, and much to what is recommended by the 2018 SCCM PADIS, or Pain, Agitation, Delirium, Immobility, and Sleep Guidelines of 2018, is to kind of use a very broad combination approach to pain, sedation in these patients. So what we're going to show you is what we have at ECMC currently for our protocol, if you will, for the management of pain and sedation for our patients, which may be slightly different at your facility, but certainly it gets along the same ideas. So in general, pain and sedation in ICU patients is going to kind of be broken down in using as-needed medication for pain, moving on to pain infusions or opioid infusions to treat that pain if that pain is still uncontrolled, with the addition of as-needed sedative medications, such as IV lorazepam or IV Versed, and moving on to an infusion of those types of agents, but not limited to just a benzo infusion like a Versed that you may or may not be more used to, but using other agents like propofol and Precedex, which are, terrific agents to utilize in an ICU patients if they tolerate it. And then moving on to specifically in our patients that end up developing some delirium, using some as needed or scheduled oral antipsychotics, which for the acute phase of sedation for your COVID and even your non-COVID ICU patients requiring heavy sedation kind of comes at the end after they've been woken up, and we're really trying to mobilize them either to get off the vent or to get to trach collar if they've made that lateral move. So a big idea within the 2018 guidelines is the term analgosedation. And what that means is using sedative or opioid infusions such as fentanyl to not only provide some pain relief, which we know that these patients have a lot of different kinds of pain. So they're not necessarily the trauma patient that myself or Dr. Cooper or the other trauma surgeons see every day, but they have a lot of different types of pain. So pain from the vent or the ET tube, pain from lying in bed all day, procedural pain from the lines and chest tubes that you all are placing in these patients for various reasons. So we want to treat their pain first, and we kind of get a 2-for-1 out of a sedative infusion or a pain infusion. And I tend to use those terms interchangeably, so forgive me for that since we are just talking about pain. So we get a kind of 2-for-1 out of our fentanyl infusions and our as-needed pain medications. They provide the pain relief, and then they also provide a sedative effect that's termed analgosedation. And so in these patients, COVID positive patients, one of the biggest hurdles that you're going to need to overcome is get the patients as synchronous with the ventilator as possible so that you can adequately ventilate them and they can adequately oxygenate, since this is their primary purpose for being on the vent. And so the approach of using as needed fentanyl or as needed dilaudid may not be sufficient. And so that is when you turn to your fentanyl infusions. And typically on admission, when patients are intubated, especially in the ED and brought up to MICU, you'll see that those fentanyl infusions are started right off the bat in tandem with as needed medication, so that you can use the as needed fentanyl to bolus the patient if you need to increase the rate on the fentanyl infusion itself. And that's one important thing to recognize for your fentanyl infusions, ultimately your Versed infusions, or even your rocuronium infusions when you need to paralyze these patients, is to utilize your as needed boluses to bolus the patient first and then increase the rate. That takes advantage of the pharmacokinetics of the drug itself, so how quick you're going to be able to get to a steady state. If you don't necessarily use a bolus before you increase your infusion, it will take the patient a little bit longer to reach that steady state so they get to a comfortable level. So that's one important key to remember, to not just crank up the infusions, use your bolus, and then increase your infusion. So once these patients are on their fentanyl infusions, typically you're going to have as needed sedatives, such as, like I mentioned, as needed Ativan or as needed Versed most often. And the biggest thing you'll have to remember is how your patient is presenting. So when you go and turn to a sedative infusion, you have several options, but the three main ones that we have in the ICUs that we even use in trauma every day are your propofol infusion, your Precedex or dexmedetomidine infusion, and your Versed or midazolam infusion, so your benzodiazepine. There's been a big shift in the last few years from being very heavy on the benzodiazepine infusions to transitioning more to the non-benzodiazepine infusions for adequate sedation of your ICU patients. So your propofol and your Precedex. And the main thing that you're going to have to think about when your patient presents to you is their hemodynamics, their renal function, and their heart rate as well, because any one of those agents are going to give you kind of different effect. Propofol and Precedex are great combination agents to use to sedate your patients, but the biggest drawback to those two infusions are the hypotensive and bradycardia that they may bring. Hypotension is more pronounced with propofol, and bradycardia and some hypotension is more pronounced with Precedex. So certainly if your patient is already presenting to your ED or post-intubation with hypotension, that might not necessarily be a great agent to pick for them right off the bat until they stabilize. But is certainly a wonderful agent for those otherwise hemodynamically stable patients that you have intubated that you need to use a sedative infusion alongside your opioid infusion for adequate sedation on the ventilator that they're going to be on. When you're not able to use those two agents, Versed infusion, even though we do tend to not like benzos because they are agents that increase the likelihood of delirium. So ICU patients are already at very high risk of developing delirium throughout their ICU stay. So patients are roughly already at like a 60% chance of developing delirium, and the addition of a benzodiazepine can independently increase that probability to 70 or 80%. So it gives them a higher chance to develop delirium, which means longer time on mechanical ventilation once their acute insult, in this case COVID, and the immunomodulatory response from COVID kind of resolves itself. And there's also been speculation about post-ICU mental health impact, so PTSD and whatever have you, from the development of delirium through their ICU time. So like I would kind of let in, benzos, we don't necessarily rely on them right now, or in a general sense for our ICU patients, but these COVID patients are going to be requiring a lot of ventilator support and are gonna often be having a lot of asynchrony on the vent, dysynchrony on the vent. So you may have to lean on your Versed as well. So I would say those 3 agents are good 3 options, depending on how your patient presents, as long as you're adequately sedating them in order for them to be synchronous with the vent. And a 4th agent that we don't often talk about, but is a really great agent that some folks are more comfortable with using, is ketamine. So that's our general anesthetic. It's an NMDA antagonist, and it's a really great agent if patients have renal dysfunction and are also hypotensive, because ketamine doesn't necessarily have that hypotensive side effect that propofol may have or Precedex may have, and it often provides a deeper dissociative sedation for these patients. I know at least in our ICU at ECMC, we probably have a good 30 to 40% of the patients on ketamine infusions and fentanyl infusions. And the rest of the patients are kind of divided between propofol and propofol Versed. So you kind of have a smattering of all 3. Folks tend to be more wary and cautious when using ketamine, only, I think, probably from not utilizing it as often. It's not really in our everyday rotation. It's kind of our back pocket sedative infusion that we use when we kind of exhaust all options. Since you guys won't necessarily be treating trauma patients, really the one big holdback, at least in the trauma ICU, is the potential for increased ICPs with ketamine, which is a notable side effect, but actually does not necessarily happen as often as would be interpreted in the literature. So I think that if your hospital has some ketamine available, and your patient doesn't necessarily fall into the just propofol, or you don't want to try the just Versed route, I think ketamine's a great option. We dose our ketamine infusions in milligrams per hour, but your place might do it in mics per kilo per minute. And usually about 1 to 2 mics per kilo per minute is where you're going to start with your ketamine infusion, pending the protocol at your hospital. So do you have any questions so far? Hopefully I've made some of that clear. That's more of a broad pain sedation overview.
Yeah, I think that that's a really great start for everybody. One of the questions I was thinking about as you were talking about the different drips that we can use as ventilator dyssynchrony is a challenge. And you had, and you might be getting to it, but I was wondering what would be the best approach for a patient who we've decided to paralyze. So we put them on rocuronium. We're not going to paralyze a patient without giving them sedation. Also, obviously, some of the things you've already mentioned, like hemodynamics, are important. But I guess my question is, if you don't have parameters to titrate to, how do you pick a medication and a rate?
Yeah, so that's a really great question, and a lot of it is going to have to do with their synchrony on the vent. Since you're not necessarily able to, so let me step back. So where I trained for my pharmacy critical care, it was not unheard of to monitor patients' sedative infusions with Versed with a BIS monitor. So that was kind of and I haven't used it in almost 8 years, but it was a monitor to determine how deep a level of sedation the patient had while they were on a rocuronium infusion or a paralytic. So it kind of monitored, I don't know the ins and outs of it, but it kind of monitored electrical activity, and then interpreted that as level of sedation. So you would aim for some level on your BIS monitor, but not all hospitals have that. I don't even know if that's really current practice anymore, since it was more of a interpretive kind of situation. So now it's going to be vital signs mainly, which is not the best way to monitor for pain or sedation, but that's really one of the only things that you're going to have along with ventilator synchrony, for you to assume that your patient is not adequately sedated. So that would be when you would increase your rate of infusion until you've reached a point where your vital signs have stabilized, which again, I completely understand. That's not a good parameter to do it by, but it's one of the only ones that we're gonna have. And then also the synchrony on the ventilator itself, once you've increased that rocuronium infusion.
Great, thank you.
Yep. So, so we've talked about a little bit about pain infusions with fentanyl, sedative infusions with our 4 big agents. And depending on which agent you choose, you may need to also monitor whether or not those agents are getting to a toxic level, if you will. So one of the biggest ones that you're going to be monitoring is propofol. So propofol-related infusion syndrome, or PRIS, was pretty well documented in children, male children utilizing high infusion rates for a defined duration of time, which, you know, a few days. And what that turned out to be, PRIS, was a hemodynamic instability that was unresponsive to any sort of intervention, like your inotropes or vasoactive agents, because there was, in theory, mitochondrial damage. And that's why you went into this hemodynamic response. So some really easy parameters to monitor your propofol infusion. I know at ECMC we do it daily, but we do monitor triglycerides and CK levels. Triglycerides, because propofol is within a lipid emulsion. And so when you see your triglycerides go over 500, that's kind of our cutoff. And the cutoff in some of the literature where if your patient is trending higher and higher above 500, it's more likely that they may develop PRIS, or the propofol-related infusion syndrome. CKs, because patients also on who become toxic on propofol also develop rhabdomyolysis. And then, you know, acute renal dysfunction, or AKI, secondary to the rhabdo. And so the cutoff for CKs is going to be 5,000, and anything above that is really, we're hesitant to continue our propofol. So even if your patient is hemodynamically stable, if those parameters that you're monitoring are climbing and trending towards the possibility of becoming accumulating the agent and becoming toxic on the agent, then you may have to think of going to either a ketamine drip if you're not already on one, or a Versed infusion, again, if you're not already on one. So that's important to note as well. Any questions with the monitoring? We don't typically monitor Versed drips. When patients are being woken up and don't wake up, you can get a benzodiazepine level. But that level is really not there for interpretation for level of sedation, just that sedation or that sedative medication is on board, and you trend it to see if the patient's clearing it. So going back to your other question about, you know, how do we know to monitor increasing the patient's infusion on a rocuronium drip? You cannot use a benzodiazepine level to give you any sort of interpretation of level of sedation. My level of sedation, my benzo level might be 15, and I might be knocked out cold, knocked out cold. But my neighbor's benzo level might be 2,700 and they're walkie-talkie. So it's really
Well,
just.
we've seen how your neighbors party, so.
I mean, it's true. I have really great neighbors, and that's why I haven't moved.
That's helpful. And I think from my perspective, one thing that I've noticed as we've made this transition to using less benzodiazepines, and you may have mentioned this, was how the active metabolites really tend to linger from the Versed also. And so it just, now that we're so used to using these other agents of Precedex and propofol, I find that for the patients that we are kind of stuck using Versed on, that they really do just take so much longer to wake up, and it's such a rockier process. And so while sometimes we have no choice and we have to use those agents, I think in practice, even in the past 10 years since I was a resident in the unit, it's just really been a full, complete change and for the better.
Yeah, and I completely agree with that. I think our patients are waking up a lot quicker, getting them off of mechanical ventilation a lot sooner, and they have a lot better outcomes because, as you noted, the Versed does have an active metabolite, and so in renal dysfunction, not only do you have delayed excretion of the parent drug, but since the metabolite is active as well, you have delayed excretion of the metabolite. And then also, Versed is a fat-loving molecule, and so with the heavier population within Buffalo, our patients tend to be more obese, and so Versed tends to sequester itself within the adipose tissue, and so it takes them a lot longer to wake up, because then you'll have that delayed release from the adipose tissue of the Versed, and so you'll have to release that as well because you've filled your stores in your adipose tissue. You turn off your drip, your intravascular stuff goes away, but then your adipose starts to release it, and that takes longer as well. But yeah, I think that it's been a really great switch for the better. We still use all three agents and sometimes ketamine in certain situations, at least in the trauma population. You'll probably find yourself using it more in COVID patients. But I think that they're having great outcomes. One of the things to recognize is that once your patients are at that point where we are trying to get them off the ventilator and trying to wake them up, so we're doing our pressure support trial. So this patient has gone from really sick with COVID to turning a corner, and they're at that point where you want to try to decrease their vet requirements. They're doing really well. You want to put them on pressure support. You've taken them off the rocuronium infusion. One of the things that your hospital may have is a daily awakening trial. And so while you will not be doing that while they're on rocuronium, because it would be a little cruel to take patients' sedation off when they are paralyzed, but once they've gotten past that point, you might start hearing daily awakening trial with your daily weaning trial. And that's really going to be per your institution's protocol. A lot of them are protocolized, where you either stop the sedative infusion or at least cut it by X amount every day to wake them up a little bit. But I think that, long story short, our transition from Versed to propofol and Precedex makes that transition a lot easier and smoother as well, because you can awaken your patients. So that was a long to do for your short statement.
No, I think that's great. I don't know if you're planning on getting into this already, but speaking of trying to get people off of drips, do you have recommendations for what sorts of PO agents or long-acting IM or other types of agents can be used as we try to wean people off of these drips?
Sure. That is going to, again, be very individualized, but some of the PO agents, because these patients are on infusions for so long, we tend to they become acclimated to the infusions that we give them. And some folks don't do as well with just cutting off the infusions and not having any sort of background replacement. And so some of the approaches that you would kind of pull for are using oral agents and as needed agents to get them off the infusion, so you can kind of do a longer titration off. Because one thing from the pharmacy perspective is that everybody is very aware that there's a limitation on PPE. The same thing is going to happen with our pharmaceutical agents that we're going to rely on heavily to make these patients comfortable. And so they can't be on infusions for the duration of their hospital stay. We do need to get to a point where we either take the infusion off without standing scheduled oral medications or with standing oral medications. And that landscape changes every day. So last week we were concerned about propofol, but at the end of the week, or actually on Wednesday, we got a giant shipment in. So it oscillates, it's very volatile with the medications that we're getting in our orders. So besides that, some oral options for a fentanyl infusion. Being in trauma, I tend to gravitate more to methadone. Since these patients are more polysubstance, you get a little 2-for-1 with that as well. And it has a very long half-life. And so it's really nice. It almost slowly titrates itself. Like one would think of a Valium taper for alcohol withdrawal. So that's always an option to schedule methadone. One thing to really keep in mind that should not be an issue at the point that you're trying to wean patients off the fentanyl infusion is the impact on QTC. So methadone has an impact to prolong QTC, and patients that are being actively treated for COVID are often on azithromycin and Plaquenil, which we are using in hopes to mitigate their illness on COVID. And so those two agents have a really big impact on prolonging QTC as well. And so the more agents that you add on to prolong QTC, the higher the risk of that happening is. And not to be scared of using the agents. We just get routine EKGs to monitor, and once they hit 500 or above is when we need to back off. And that's going to be the same situation when we talk about delirium management, because some of those agents also prolong QTC. So I really like methadone. And then scheduled oxycodone for those folks that do well on scheduled oxycodone as well, the immediate release. So those are two agents for pain. There has been a tendency to transition patients on stable fentanyl infusion rates to a fentanyl patch. That is a little bit more difficult, I think, because you have to be more cognizant of the patch being on. It's not as easily titratable as an oral agent might be. So I don't necessarily recommend that, but you might see that as an option at your institution as well. But that's not necessarily something that I pull for unless they are long habituated or previously on a fentanyl patch. Then that would be an option for your patients. For Precedex, I really like clonidine. So clonidine is also works on alpha-2 or alpha-1. And so Precedex works centrally, and clonidine has that same effect. It's basically the oral version of Precedex. And so you start at clonidine 0.1 milligrams down their tube every 8 hours or every 6 hours. Doesn't matter which way. If they're tolerating Precedex, they most likely will tolerate the addition of that clonidine, but you can always put holding parameters for blood pressure for your systolics. And then you increase the clonidine as you decrease the Precedex. And then typically patients are able to transition off that Precedex drip pretty rapidly. And then you can titrate off the clonidine from there, whether they go to the floor or if there's a step-down unit in your institution. Oftentimes our trauma patients are in our unit long enough for us to titrate the clonidine off ourselves. There really is no good oral equivalent, I would say, to propofol. But we get a little 2-for-1 with quetiapine, so Seroquel. Like I mentioned earlier, a lot of ICU patients have a high risk of developing delirium, and adding any sort of additional sedative infusions like a benzodiazepine increases that risk. And so atypical antipsychotics are mentioned within the PADIS guidelines as an option to help agitated delirium. They're not utilized as a pre-treatment to developing delirium, so you can't prophylactically give them quetiapine or as needed Haldol or as needed Zyprexa, so they don't develop delirium. But we use it so that if they do develop agitated delirium, we use it for the side effect. We use it for the drowsiness, and it helps to calm them down. So I suppose that you could use, well, I don't suppose, we often use Seroquel as an oral agent when we're trying to get off our infusions like propofol. But again, there's no like propofol equivalent like there is for opioids and and Precedex. So you can start with quetiapine, go low, start low, go slow. So 25 milligrams every 12 hours, but you can push that dose pretty high pending what your patient needs, but I wouldn't necessarily increase your dose faster than every day or two. And again, quetiapine also increases QTC prolongation. So depending on other agents your patient is on, you'll need to routinely grab an EKG, especially as you get towards those higher doses. So the more agents you have and the higher doses that they are, you'll have a higher likelihood of having QTC prolongation. And then with that, we try to utilize non-benzodiazepine as needed medications. So once they've transitioned to oral, you can either use a Haldol IV or a Zyprexa or olanzapine IM. The olanzapine, you don't have to dose as frequently. So typically you could do that like every 8 to 12 hours. 10 milligrams every 8 to 12 hours IM. For agitation, we try to maintain, we use SAS at ECMC, so we try to maintain a SAS of 3 to 4. Or you could use Haldol IV, usually 5 or 10 milligrams IV every 4 to 6 hours. And again, the more doses you administer, the higher risk of prolonging QTC. So keep that in the back of your mind. I sound like a broken record, but you'd be surprised, even the young folks tend to creep up with their QTCs, which you wouldn't necessarily expect. So that's the last thing that you want is a patient to go into torsades. Is that clear with the, yeah. I know that there's kind of like a lot. There's the patients, they don't fit in the pretty boxes like in the PADIS guidelines would like you to assume. So it's going to be pretty individualized.
Yeah, I think it's just great to know all of the options that are available and all of those considerations. And I think a big summary is that once you start throwing a lot of these things on, it's just a regular EKGs
yep.
for a lot of it. But I think that those covered most of the burning questions that I had. Was there other stuff you were planning on covering?
Not necessarily for our COVID patients. If you end up no, I guess not for our COVID patients. One of the things that if you are familiar with the PADIS guidelines and that we practice in the trauma surgical realm is the multimodal analgesia. And so, your schedule Tylenol, your lidocaine patches, your neuroleptic agents, so gabapentins and Lyrica, and your NSAIDs, like and your NSAIDs.
Toradol.
Thank you. I wanted to say torsemide because I'm listening to Paddington in the background. So Toradol, one thing to keep, and you can still use most of those approaches probably in your COVID patients, even though they're not really titratable, but one thing to avoid that is very specific to COVID patients is the NSAIDs, as we briefly chatted about offline, because of the theoretical increase in the ACE2 expression, which in theory increases patients' risk of poor outcomes from COVID. It's not necessarily well understood, but they have tried to make that connection. So just to avoid those agents, those NSAID agents in your patients. Particularly, I think that people would pull for them for fever, so ibuprofen for fever. I would personally suggest staying away from ibuprofen for at least fever, because you're not going to be doing multimodal analgesia in these patients, and not using the ibuprofen for them.
Okay, great. Well, I think you've given us a great overview of the drips that we may use for sedation, along with ways to get off of those drips, PRNs we can use in difficult patients, as well as PO medications that we can help to optimize, all with the goal of taking care of these very difficult and somewhat unique, but still critical care patients. So thank you very much, Graz. We really appreciate your time, and we hope everybody found this helpful.
Yeah, thanks for having me, and good luck, everybody. Hopefully you won't have to use all of this information we gave you, but hopefully it comes to be helpful.